I'm Anne Woolfield.
I'm Mel Akerman.
And I'm Carla Pecoraro, and we're your hosts of the Uterine Sound podcast, bringing you up-to-date information on all things O&G.
Welcome to the final episode of our mini-series on preterm birth. In part 1, we discussed the background, pathophysiology, and risk factors for preterm birth. And last week, we covered diagnosis and management. Today, we'll focus on the most important topic, how to prevent preterm birth.
The first step to reducing preterm birth is addressing modifiable risk factors. These include smoking cessation, optimizing BMI, spacing pregnancies by 18 months, and optimizing medical conditions prior to pregnancy. We can also look at surgical correction of uterine anomalies or offering medical instead of surgical management for miscarriage or termination. The risk of preterm birth from multiple pregnancy can be reduced by single embryo transfer or multi-fetal pregnancy reduction.
The next prevention strategy is to identify pregnancies that are more likely to end in preterm birth and to treat them with progesterone or cyclage. We do this through cervical length screening. Universal cervical length screening is recommended for all women between 18 to 24 weeks gestation by Ranscog, FIGO, and ACOG and can typically be done at the morphology ultrasound scan. The rationale for this approach is that more than 50% of preterm births occur in low-risk women, that a short cervix length is associated with an increased risk of preterm birth, and that universal cervical length screening and treatment has been shown to reduce the risk of preterm birth. Screening at the time of the morphology ultrasound has also been shown to be cost-effective and well-tolerated. If we only screened women with risk factors, we would actually miss about 40% of women with a short cervix who are at risk for preterm birth, which is why we recommend screening everyone.
In women who are high risk for preterm birth, we would perform a fortnightly transvaginal cervical length measurement from 14 to 16 weeks to 24 weeks of pregnancy. This is because these women are much higher risk of cervical shortening at an earlier gestation. In general, the shorter the cervix and the earlier the shortening is detected, the higher the risk of preterm birth. Now, that's not to say that women with a short cervix will definitely go into preterm labour. Actually, most women with a short cervix will still deliver at term, but identifying a short cervix allows us to reduce the risk of preterm birth by treating with progesterone or cyclage.
Now, the definition of high risk depends on your institution, but it typically includes the history of spontaneous preterm birth below 34 weeks, second trimester pregnancy loss at 16 to 24 weeks, not due to fetal anomaly or placental dysfunction, previous PPROM, previous use of cyclage, history of trachelectomy, or a known uterine variant. Interestingly, the indications for serial transvaginal cervical length don't include previous LETs or a cone biopsy, and these women can be safely screened at the 20-week scan. What's the deal with starting at 14 weeks and stopping at 24 weeks? Couldn't we just start screening earlier? And why don't we just keep screening the cervical length after 24 weeks so we know who will go into preterm labour?
We don't measure cervical length before 14 weeks because it can be more difficult to differentiate between the lower uterine segment and the cervix, as the pregnancy hasn't yet expanded to the whole uterus. Studies looking at first and early second trimester cervical length have also not shown that cervical measurement at this time is helpful in predicting preterm birth. The reason we stop at 24 weeks is because the relationship between a short cervix and preterm birth is strongest before 24 weeks. Routine screening after 24 weeks provides limited clinical value, and there is no data suggesting that it improves outcomes. After 30 weeks, cervical length measurement is generally not useful for predicting preterm birth because the cervix physiologically starts to shorten at this time. Now remember, we are talking about asymptomatic patients here. Patients presenting with threatened preterm labour are a different population, and in this group, cervical length is used to identify those who are unlikely to deliver preterm, thus reducing unnecessary interventions like steroids or tocolysis.
Okay, so, and what do we mean by short cervix? How short is too short?
In Australia, a short cervix is defined as a transvaginal cervical length of less than or equal to 25 millimetres. That's the number you need to remember, which is found in about 1.3% of low-risk women. The reason we use 25 millimetres is because studies have reported a 30 to 40% reduction in preterm birth with treatment at this threshold. Other countries may use a threshold of less than 20 millimetres or less than 15 millimetres, depending on their clinical guideline and the patient population. Interestingly, 15% of low-risk women with singleton pregnancies with a mid-trimester cervical length, 26 to 29 millimeters, will experience cervical shortening to less than 25 millimeters before 24 weeks gestation. So in patients with a mid-trimester cervical length of 26 to 29 millimeters, consider a repeat scan in 2 weeks. The evidence for this comes from a 2021 study, which is referenced in the South Australian guideline.
Ooh, I haven't heard of this being routine in Queensland, but it's definitely something to consider. So, Mel, how do we actually measure the length of a cervix?
You can measure cervix length with a transabdominal scan, but if the cervix measures 35 millimeters or less, or is inadequately visualized, which isn't the case in 60% of women, then this needs to be followed up with a transvaginal scan. If the transabdominal cervix length is greater than 35 millimeters, then it's very unlikely that the transvaginal cervical length would be under 25 millimeters. For the most accurate measurement, we should measure cervical length with the transvaginal ultrasound, which is the gold standard test. Place the probe in the anterior fornix in a patient with an empty bladder. You want to minimize pressure on the cervix, as pushing too hard can actually increase the cervix length. To check if you're applying the right pressure, the anterior and posterior lip of the cervix should appear to be equal thickness. Next, measure the length of the endocervical canal from the internal to the external os. If the cervix is curved, you can either measure the length of the cervix as a single straight line from the internal to external os, or you can do 2 separate straight lines joined at an angle along the curve and add them together. This method should be used if the distance between the angle and a straight line from the internal to external os is greater than 5 millimeters. Generally, we take 3 measurements over at least a 5-minute period, making sure there's less than 10% difference between the measurements, and document the shortest length as the cervix length.
And for
Now,
those...
sorry, I'm going to interrupt you there, Carla. I have actually seen, the reason we do it over a 5-minute period is that the cervix is quite dynamic. I've actually seen a cervix go from being 30 millimeters to 15 over a 5-minute period.
Oh, yeah, good point. I guess for those wanting to learn more about how exactly to measure a cervical length, the Cervical Length Education and Review CLEAR program is available online. This is an American program and does have a cost to it, but it can be really helpful. The Fetal Medicine Foundation's Certificate of Competence in Cervical Assessment is another high standard certification. You said earlier that most women with a short cervix won't deliver preterm, but also that the shorter the cervix, the higher the chance of preterm birth. Is there a cervix length at which a woman would definitely go on to have a preterm birth?
You would think so, but no.
Annoying.
And those with a cervix, and those with a cervical length of less than 25 millimeters, only 18% will give birth under 35 weeks. With a cervix length less than 13 millimeters, only 50% will give birth under 35 weeks. And in those with no measurable cervix length, only 75% will give birth under 32 weeks. It's also important to note that the diagnosis of a short cervix is limited to pregnant people. Cervical length measurements performed in non-pregnant women are not useful for predicting spontaneous preterm birth.
So then how does transvaginal cervical length correlate to clinical exam? Can we actually see a short cervix on spec or feel it on a vaginal exam?
Actually, physical examination does not correlate well with ultrasound measurement of cervical length at all. Most cervixes that are 10 to 25 millimeters in length on second trimester ultrasound look and feel long and closed on physical examination. Effacement and dilation are usually not detected on VE until the transvaginal cervical length is less than 10 millimeters.
And then what about all these random findings that I'll see on an ultrasound report and I'm Googling out the back? What is funneling, separation of the membranes, or debris in the amniotic fluid? Do these increase the risk of preterm birth?
Funneling is the protrusion of the membranes into the cervical canal and is described according to the shape of the surrounding cervix, which looks like the letters T, Y, V, and U. A handy little mnemonic is trust your vaginal ultrasound. T represents the normal appearance, whereas U represents almost complete effacement and has the highest risk of spontaneous preterm birth. When funneling is present, there is a normal cervical length. It's actually usually related to a contraction and doesn't have any clinical significance. Separation of the membranes or debris and sludge in the amniotic fluid is a relatively non-specific finding, but it may suggest subclinical infection or an increased risk of preterm birth. It's not possible to tell on ultrasound whether debris is blood clot, meconium, vernix, or cellular material related to infection or inflammation, so these findings don't usually change our management.
Okay, so to summarise the key points for cervical length screening, universal cervical length screening is recommended for all women between 18 and 24 weeks, and it's typically done at the morph scan. Women at high risk of preterm birth should have fortnightly transvaginal cervical length screening from 14 weeks to 24 weeks. If the transabdominal ultrasound is less than 35 millimeters, then a transvaginal ultrasound is needed to assess the cervical length. A cervix less than or equal to 25 millimeters is considered short, and the shorter the cervix, the higher the risk of preterm birth. Then the risk is further increased if there is a short cervix and a history of preterm birth. Most women with a short cervix will still go on to deliver at term, but if we treat those with a cervix length under 25 millimeters with progesterone or a cyclage, we can reduce the preterm birth rate by 30 to 40%. So let's get into our treatment options. Why are we using progesterone?
Well, progesterone plays a huge role in pregnancy, starting with ovulation and implantation. Then, in early pregnancy, progesterone is produced by the corpus luteum and maintains the pregnancy until the placenta takes over at 7 to 9 weeks. It's so important that if you remove the corpus luteum or block the action of progesterone before 7 weeks, then the pregnancy will actually abort. Progesterone prevents apoptosis in fetal membranes to protect against PPROM. It also acts on the myometrium and cervix and maintains uterine quiescence in the latter half of pregnancy. Functional withdrawal of progesterone at the level of the uterus seems to occur before the onset of labour.
Administration of progesterone has been shown to reduce the risk of preterm birth in women with a short cervix. For women with a history of preterm birth but without a short cervix, the evidence is less clear. A 2022 systematic review and meta-analysis in the Green Journal, aptly titled, "Does Vaginal Progesterone Prevent Recurrent Preterm Birth in Women with a Singleton Pregnancy and a History of Spontaneous Preterm Birth?" It actually found that there was no convincing evidence to support the use of vaginal progesterone to prevent recurrent preterm birth. The meta-analysis itself included 10 studies, 7 with a small sample size of less than 150, and 3 with large sample sizes of greater than 600. When all of the studies were considered together, it seemed that vaginal progesterone did reduce the risk of preterm birth. However, sensitivity analysis restricted to studies at low risk of bias indicated that vaginal progesterone did not reduce the risk of preterm birth. As a result, ACOG has changed their guidelines, and a history of preterm birth is no longer considered an indication for progesterone use. Most Australian guidelines will still recommend progesterone for women with a history of preterm birth alone, regardless of cervical length. This includes RANZCOG, Queensland Clinical Guidelines, and ISUOG, also the Australian Preterm Birth Collaborative. The rationale for this approach is there's a large pool of studies that do support the use of progesterone in women with a history of preterm birth. The studies that don't support progesterone are few. And finally, there appears to be a low risk of adverse events associated with the use of progesterone. The evidence for the benefit of progesterone in women with a short cervix comes from a 2018 meta-analysis by Romero. This study showed that treatment of women with a short cervix with progesterone reduced the risk of preterm birth by 34% and improved neonatal outcomes.
Now, that is a statistic I have embedded in my brain forever. Progesterone reduces the risk of preterm birth by 34%. When I was studying for exams, I had this great idea that if there was an important fact that I needed to remember, then I would set it as a reminder on my phone. Then a little alarm would go off randomly the next day, reminding me of this fun fact, and my knowledge would be consolidated. Now, with this particular fact, I somehow managed to stuff it up, and I ended up getting this reminder every day for like 2 months. Progesterone reduces the risk of preterm birth by 34%. I will never forget it, and now neither will you.
BRB, just setting my new alarms and my new mantra and manifesting. This is going to be eat, breathe, reduce risk of preterm birth by 34% with progesterone for the rest of my life.
In those with a short cervix.
Yeah, until the next study comes out and changes the data on you. Okay, so short cervix, progesterone. History of preterm birth alone, also progesterone. Got it. Now, we keep saying vaginal progesterone this and vaginal progesterone that. Is there any other kind of progesterone?
There are two main types of progesterone used for the prevention of preterm birth: 17-alpha hydroxyprogesterone caproate, 17-OHPC, and natural progesterone. Natural progesterone is administered vaginally, typically at a dose of 200 milligrams daily. While the optimal dose hasn't been clearly established, most studies use doses between 90 to 400 milligrams and stop at 36 weeks. There seems to be no difference between 100 milligram and 200 milligram pessaries, and so either can be used depending on availability. The advantage of vaginal progesterone is that it can act directly on the uterus, since uterine exposure occurs before the first pass through the liver. Hydroxyprogesterone, or 17-OHPC, is a synthetic progestogen administered via weekly intramuscular injection. This preparation used to be available, although mainly in the US, as it was thought that 17-OHPC reduced the risk of preterm birth in women with a history of preterm birth. This product has actually since been withdrawn from the market, as the PROLONG trial, amongst others, has demonstrated that 17-OHPC actually doesn't reduce the risk of preterm birth. Oral progesterone has also been studied, but has much less evidence. The efficacy is unclear and side effects more common. So for now, this is not recommended for preterm birth prevention.
New evidence strikes again. It's so annoying when studying. Anyway, are there any other side effects to progesterone?
The most common side effect is vaginal irritation or increased vaginal discharge. There also appears to be no long-term effects on mothers or babies. The Optimum trial of vaginal progesterone was a large trial with the longest duration of follow-up and found no increase in complications for up to 2 years. Progesterone does have a cost to it, but since 2021, progesterone pessaries for preterm birth have been added to the PBS and are now significantly more affordable.
Woohoo!
For international listeners, this is an Australian thing. Listed contraindications include sensitivity to progesterone or hard fat, which is the additive to the pessary, undiagnosed vaginal or urinary tract bleeding, liver dysfunction or disease because progesterone is metabolized through the liver, known or suspected malignancy of the breast or genital organs, active VTE. There's no clinical evidence that vaginal progesterone is actually associated with a risk of VTE, but the package inserts all progesterone preparations are required to carry a warning about VTE risk. This is because the combined estrogen progesterone contraceptives are associated with an increased risk of VTE, and thus the TGA and FDA believe that there's inadequate information to determine whether specific progesterone preparations used alone are associated with an increased risk.
And I've actually heard you can use progesterone rectally if you can't use it vaginally, although this may increase the risk of flatulence and constipation. So let's summarize what we've just learnt about progesterone. First, progesterone is indicated for women with a short cervix on mid-trimester ultrasound or a history of preterm birth in Australia. Second, the dose is 100 to 200 milligrams of micronized progesterone administered by a vaginal pessary daily from 16 to 36 weeks. Third, side effects include increased vaginal discharge. And fourth, the most important fact,
Progesterone reduces the risk of preterm birth by 34%.
Progesterone reduces the risk of preterm birth by 34%. Okay, let's move on to cerclage. A cerclage is basically a stitch that holds the cervix shut. What are the indications for a cerclage?
There are 3 main indications for a cervical cerclage. 1, history indicated, 2, ultrasound indicated, and 3, examination indicated cerclage, otherwise termed a rescue cerclage. A history indicated cerclage is offered if there's a history of 3 or more spontaneous preterm births or mid-trimester pregnancy losses, or prior cerclage due to painless cervical dilatation in second trimester. Note that if the patient's had a previous ultrasound indicated cerclage and delivered after 34 weeks, they do not automatically need another cerclage in the next pregnancy. These patients should have a transvaginal cervical length from 14 weeks and then place a cerclage if their cervix is short. This is because only 50% of patients with an ultrasound indicated cerclage will need another one. If the patient had a previous ultrasound indicated cerclage but went on to have a preterm birth before 34 weeks, then these women should be offered a transvaginal cerclage in the next pregnancy at 12 to 14 weeks, usually after their early anatomy ultrasound. If the obstetric history indicated cerclage is also unsuccessful, then we would offer a transabdominal cerclage in the next pregnancy.
An ultrasound indicated cyclage is offered if there's a history of preterm birth and a short cervix under 25 millimeters before 24 weeks. If there's no previous history of preterm birth and a cervix length under 10 millimeters, or if the cervix continues to shorten despite the use of vaginal progesterone. Just note that a short cervix of 10 to 25 millimeters without a history of preterm birth or second trimester loss is not an indication for a cyclage. Although you can consider a cyclage if there is a short cervix and a history of cervical trauma, like a Let's or cone biopsy, or if there was PPROM in a previous pregnancy.
An examination-indicated cyclage, or a rescue cyclage, is offered if there's evidence of cervical insufficiency based on a dilated cervix on examination at 16 to 24 weeks.
I just love the word cyclage, and I love saying it.
It is actually quite nice to say, isn't it?
Anyway, a short cervix with a history of preterm birth is an indication for progesterone, but also for cyclage. Does that mean we can use both?
The current guidelines state that women with both a history of spontaneous preterm birth of less than 34 weeks or a mid-trimester loss from 16 weeks and a short cervix should be offered a choice of vaginal progesterone or cyclage. There's no actually RCT to directly compare vaginal progesterone and cyclage in this population. However, an indirect comparison indicated that both are equally effective in the prevention of preterm birth. You can consider progesterone in addition to cyclage, but there actually isn't evidence of an added benefit to using both, and the ARCOG guideline recommends against this.
And who shouldn't we be giving a cyclage to?
In general, we would avoid a cyclage if there is any suspicion of infection. A cyclage is unlikely to be effective in the presence of intraamniotic infection, and prolonging the pregnancy actually places the mother and baby at increased risk of sepsis. We typically rely on clinical features to assess for the presence of infection, but definitive diagnosis actually requires amniocentesis. Now, some practitioners do perform amniocentesis before cyclage to rule out infection. However, there are no randomized controlled trials to confirm the usefulness of this. In general, amniocentesis is not required before history-indicated or ultrasound-indicated cyclage because the prevalence of subclinical infection is about 2% in asymptomatic patients with a closed cervix. Where it may be more helpful is in the case of a rescue cyclage, where the incidence of intraamniotic infection ranges from 10 to 50%. When the cervix is greater than 2 centimeters dilated, the rate of infection is somewhere between 20 to 50%, and when the cervix is less than 2 centimeters dilated, or if there are ultrasound findings consistent with inflammation, like debris or sludge in the amniotic fluid, the incidence of infection is probably no more than 5 to 10%. Still, cultures take time, and it may be detrimental to wait 48 hours for culture results to return before performing the cyclage. So in Queensland anyway, most people tend to not do an amniocentesis.
PPROM is another contraindication to cyclage. Generally, you want to avoid introducing foreign bodies in the event of PPROM, as they can increase the risk of infection and sepsis. Mums with infections can actually get quite sick, and we really want to avoid that as much as possible.
Active labour is another contraindication. Once labour has started, a cyclage would be unhelpful and may actually tear through the cervix as the cervix continues to dilate. This is the reason why we recommend a cyclage be removed at the onset of labour. Active bleeding, evidence of fetal compromise, lethal fetal defect, and fetal death are also contraindications to cyclage.
And while we're on the topic, the following are not indications for cyclage: multiple DNCs or cervical surgery previously, a Müllerian anomaly, funneling of the cervix without a cervix length less than 25 millimeters, incidentally detected short cervix without a history of preterm birth, multiple pregnancy without a short cervix, and that's it. So now let's talk technique. How do we do a cyclage?
Transvaginal cyclage is the most common, and there are two techniques, the Shirodka and the McDonald technique. The McDonald technique is most common and is much easier to perform than Shirodka. Basically, a circumferential suture is inserted anteriorly at the junction between the ectocervix and the vagina. 4 to 6 bites of the cervix are then taken to complete the suture, which is tied anteriorly. You can tie posteriorly, but it's a bit more difficult to remove. Wherever you tie it, make sure you tie 2 knots, one at the cervix and one about 1 to 2 centimeters away from that knot. This allows you to grasp the knot to identify the cervix easily when you go to remove the suture. Just make sure you document whether the knot is anterior or posterior. Now, if the membranes have prolapsed through the cervix, the risk of iatrogenic PPROM is up to 65%. Therefore, the prolapsed membranes must be replaced into the uterine cavity before applying the cerclage. This can be achieved by a few things: steep Trendelenburg position, use of a uterine relaxant like GTN, filling the bladder, pulling the cervix forward over the membranes, or pushing the membranes back with a gloved finger, or a fluid-filled condom or a bladder catheter balloon. Bit risky. You can also use amnio reduction to remove about 150 to 250 mils of amniotic fluid to reduce the pressure in the prolapse sac, allowing it to retract back into the uterine cavity. But currently, this is not recommended by ARCOG.
The Shirodka technique is less commonly used. With this technique, the vesicovaginal and rectovaginal fascia is reflected to the level of the internal os, allowing the suture to be placed higher up. Merceline tape or Ethibond suture is then placed as close as possible to the level of the internal os. Basically, you just want to use a strong, non-absorbable suture. Both techniques are equally effective, but the Shirodka technique does require anesthesia for removal because the suture knots are often embedded under the epithelium.
Abdominal cerclage is an elective procedure that can be performed by laparoscopy or laparotomy. It can be inserted in between pregnancies or early in a pregnancy. The indications include where the cervical anatomy does not allow the placement of a cervical cerclage, for example, after a trachelectomy, or after a failed ultrasound-indicated transvaginal cerclage, defined as a failure at less than 30 weeks. This procedure is more complicated than a transvaginal cerclage, and it's associated with greater morbidity like wound infection and healing. Vaginal birth is not possible after this approach, so cesarean is necessary for the birth of the baby. The Caesar is typically performed at 36 to 37 weeks because there's a potential for uterine rupture if labour occurs spontaneously. The cerclage can be left in situ if the woman wants to go on to have future pregnancies.
And what about after the cerclage? Do we need to give antibiotics or tocolytics?
Prophylactic antibiotics have been considered to reduce the risk of intraamniotic infection. Indomethacin has been considered because cerclage placement has been associated with transient elevation in prostaglandin levels, and prostaglandins can induce uterine contractions. There is limited available evidence on the use of prophylactic antibiotics, indomethacin, or other tocolytics to improve the efficacy of cerclage, and thus ACOG and ARCOG do not make a strong recommendation for or against use of either of these. In our experience, it's really clinician dependent. Some MFMs like to use indomethacin, others don't. We suggest you rely on the most experienced person in your department for advice on your hospital's policy. In general, antibiotics and indomethacin are not typically used for history or ultrasound-indicated cerclage, but they may be used for rescue cerclage with a suggested regime outlined on Up to Date. After the cerclage, we also don't typically recommend bed rest, avoiding intercourse, or ongoing transvaginal cervical length measurement, as none of this is supported by evidence.
Yeah, none of the patients believe us when we say you can have intercourse. I don't think anyone does. I don't know.
I don't think I'd be having intercourse with a cerclage.
Scan.
Absolutely.
Yeah. And what's the best time to put in a cerclage, and when do we take them out?
Most cerclages are placed between 12 and 24 weeks. We typically don't do a cerclage before 12 weeks, as most miscarriages due to aneuploidy occur in the first trimester. Waiting until the end of the first trimester permits an ultrasound evaluation for fetal anomalies, screening, and diagnosis for chromosomal abnormalities that might affect the decision to continue the pregnancy. After 24 weeks, most clinicians will avoid placing a cerclage since the procedure may cause accidental rupture of the membranes, leading to extremely preterm birth. A meta-analysis of 4 RCTs of cerclage versus no cerclage at 24 to 26 plus 6 weeks also found that cerclage did not significantly reduce preterm birth or improve neonatal outcomes. We definitely don't do it after 28 weeks because a delivery after this gestation is likely to have a reasonably good outcome. Plus, cerclage at this gestation may actually increase rather than decrease the risk of preterm birth.
Cerclages are removed electively at 36 to 37 weeks, but if the woman is having a planned caesarean section, then you can delay removal until the time of the Caesar. If the woman goes into preterm labour, it's important to remove the cerclage straight away to avoid cervical laceration or uterine rupture. Usually with McDonald's cerclage, there are 2 knots. Make sure you've cut the knot closest to the cervix and not the distal knot. I've made that mistake before, and hunting for that second knot after you've accidentally cut the first knot is not a good time. A Shirodka cerclage usually requires anesthesia for removal, and all women with a transabdominal cerclage require delivery by caesarean section, and as Anne said, abdominal cerclages can be left in place after delivery to facilitate the next pregnancy.
Then what happens if the woman P-proms?
This is another area of debate. Removing the cerclage may lead to earlier birth. However, keeping the cerclage in after P-prom may increase the risk of infection leading to preterm birth and increased neonatal and maternal morbidity. You could consider a delayed removal for 48 hours in women with P-prom between 24 to 34 weeks without evidence of infection to allow for steroids and intrauterine transfer. There's no advantage for delayed removal if P-prom is less than 23 weeks or greater than 34 weeks due to the risk of neonatal and maternal sepsis and minimal benefit of latency. The only RCT of cerclage removal versus retention after P-prom found no significant difference between groups in any pregnancy outcome, so infection, prolongation of latency, composite neonatal outcome. However, there was a trend in the direction of less infectious morbidity with immediate removal of the cerclage. If there's no obvious infection, bleeding, or preterm labour, then you could leave the cerclage in place. But there is an increased risk of ascending infection with poor outcomes, and so most clinicians would usually remove it.
And what are the risks of the cerclage? Like, what should we be advising women?
There is a small risk of intraoperative bladder damage, cervical trauma, membrane rupture, and bleeding during insertion of a cerclage, but this only occurs in about 1% of patients. Fistula formation has been reported as a late and rare complication. Cerclage may be associated with a risk of cervical laceration or trauma if there is spontaneous labour with the suture in place, and this can lead to cervical dystocia or uterine rupture, although this is rare. For women undergoing non-emergency cerclage, vaginal cerclage insertion is not associated with an increased risk of postoperative P-prom, chorioamnionitis, induction of labour, or caesarean section. The insertion of a cervical suture is also not associated with an increased risk of preterm birth or second trimester loss. Abdominal cerclage complications include pregnancy loss and fetal growth restriction from inadvertent ligation of the uterine arteries.
Ooh, interesting. Are there any special considerations for twin pregnancies, Anne?
Multiple pregnancies are an increased risk of preterm birth. Unfortunately, progesterone or cerclage for unselected twin pregnancies does not seem to reduce the risk of preterm birth. Women with twins with a history of preterm birth and a current short cervix may be reasonably prescribed progesterone. The evidence for this is based on a 2022 meta-analysis showing that progesterone in these women reduced the risk of preterm birth with a relative risk of 0.6. It should be noted, however, that the data for this is based off studies with a limited number of participants, and there's a wide confidence interval. Not providing progesterone supplementation in these circumstances is also reasonable.
A cerclage can also be considered for twins on a case-by-case basis. In a meta-analysis of ultrasound-indicated cerclage in twin pregnancies, cerclage was associated with prolongation of pregnancy in those with a cervix length under 15 millimeters, but not in patients with a cervix length of 16 to 24 millimeters. Also, most of the data supporting this came from retrospective cohort studies. When only RCTs were analysed, ultrasound-indicated cerclage was associated with higher rather than lower risks of low birth weight.
Okay, excellent. Time for a quick recap and a summary of cerclage. So, a cerclage is a cervical suture that reinforces the cervix and supports it staying closed. There are 3 groups of indications. History indicated, which includes 3 or more spontaneous preterm birth or mid-trimester losses, or a previous rescue cerclage. An ultrasound indicated, which includes a history of preterm birth and a transvaginal cervical length less than 25 millimeters or a transvaginal cervical length of less than 10 millimeters, and ongoing cervix shortening despite progesterone. Finally, examination indicated or rescue, and that's when there's cervical dilatation detected on clinical exam. The contraindications include P-prom, labour, infection, fetal death, fetal anomaly, and bleeding. And the risks include P-prom, bleeding, infection, cervical scarring, and dystocia and fistula formation. The most commonly used transvaginal approach is the McDonald technique, but you could also use the Shirodka technique, which involves reflection of the recto and vesicovaginal fascia. Abdominal cerclages are reserved for people with a trachelectomy, which is removal of the cervix, or those who have failed a transvaginal cerclage previously. Cerclage should be removed at the first sign of preterm labour or at 36 to 37 weeks. Cerclage removal can be done in the clinic if it's a McDonald suture, or in theatre under anaesthetic if a Shirodka technique is used. Abdominal cerclages don't require removal. And we love the word cerclage. Are there any other things we can use? What about pessaries or aspirin?
The theory behind the use of vaginal pessaries or rings is that they alter the axis of the cervical canal and displace the weight of the uterine contents away from the cervix. The pessary can also, in theory, obstruct the internal os by changing the angle of the cervix relative to the uterus and may provide protection against ascending infection. So far, evidence has shown that pessary use does not result in a reduction in preterm birth or any improvement in neonatal outcome. So for now, pessaries are not recommended for prevention of preterm birth.
Aspirin is another medication that's been studied for the prevention of preterm birth. There's evidence that aspirin can reduce the risk of preterm birth if given to women at high risk of preeclampsia. This is mainly through reducing the chances of developing preterm preeclampsia and the need for indicated preterm birth. There's also a theory that low-dose aspirin may reduce the risk of spontaneous preterm birth by inhibiting the inflammatory pathways that lead to preterm birth. Aspirin is currently not recommended for the prevention of preterm birth in patients with a low risk of developing preeclampsia. The two relevant trials are the aspirin trial and the April trial. The aspirin trial evaluated the use of low-dose aspirin for the prevention of spontaneous preterm birth. 12,000 women, 12,000 women were randomized to 81 milligrams of aspirin from 6 to 13 weeks until 36 weeks. In this trial, aspirin did reduce the risk of preterm birth and also reduce fetal loss and perinatal mortality. These benefits mostly occurred because of a 60% reduction in participants who gave birth before 34 weeks due to a hypertensive disorder. The April trial looked at the effect of 80 milligrams of aspirin versus placebo in 387 patients with a history of spontaneous preterm birth from 8 to 16 weeks until 36 weeks gestation. In this study, low-dose aspirin did not result in a statistically significant reduction in preterm birth. However, the April trial was underpowered to provide a definitive answer, and a trial with about 4,000 participants would be required to determine if aspirin can prevent recurrent preterm birth. We look forward to more data.
And then I'll reset my reminder, my new mantra. So to summarize other tried and tested measures that don't seem to work, we have prophylactic tocolytics, home uterine contraction monitoring, bed rest because it doesn't reduce preterm birth, but it does increase the risk of venous thromboembolism, deconditioning, and poor mental health. Avoiding intercourse, although it's difficult to convince patients of this. Empiric antibiotic therapy, and treating periodontal disease. And this wouldn't be a preterm birth series if we didn't talk about the Every Week Counts National Preterm Birth Prevention Collaborative. Now, this is a great initiative that aims to safely lower the rate of preterm and early term birth across Australia by 20%. This collaborative is supported by the Australian Preterm Birth Prevention Alliance, Women's Healthcare Australasia, the Institute for Healthcare Improvement, and Safer Care Victoria, and it's funded by the Commonwealth Government. It basically involves a package of evidence-based changes shown to be effective in improving outcomes, and then it helps hospitals to implement those changes and share data about their work to lead to better outcomes. The key elements include supporting smoking cessation, no pregnancy to be ended before 39 weeks without obstetric or medical intervention, measurement of the cervix length at all mid-pregnancy scans, use of vaginal progesterone if there is a history of preterm birth or if the cervix is less than 25 millimeters, considering cerclage if the length of the cervix continues to shorten despite progesterone, and continuity of care from a known midwife during pregnancy. We can't wait to see the results of this fabulous initiative.
Well, that wraps up the final episode in our preterm birth mini-series. We hope you've learnt something and feel a lot more comfortable managing patients at risk of preterm labour.
As usual, you'll find our references on the website, a summary of our content on our Instagram later probably in the week.
If there's anything we haven't covered, feel free to email us with any questions and we'll try to cover it for you in an upcoming episode.